I'm delighted to talk with you all today about acceptance and commitment therapy, or ACT, with CF. I'm going to kind of tell you a bit about what is ACT and why in particular this is a really great treatment for people with CF right now, like summer 2020 right now. So my disclosure, as Jim had mentioned, my whole project here is generously funded by the Boomer Esiason Foundation. Thank you. This has been like a life-changing, career-changing grant. And I'm so delightful to have had the support to be able to run this trial, which we'll hear a bit more about. So if we were meeting in person, maybe we'd be sharing some fancy lattes, or we'd be drinking a blow pop martini. Maybe we would be at some sort of luxurious outdoor venue or lying in our hammocks. But here we are, 2020, womp womp. And what we're going to talk about today is some time-sensitive considerations and applications of ACT. What is ACT? Why telehealth? Pilot study findings, and then the current study, our multi-site randomized control trial of ACT versus supportive psychotherapy for people with CF. So this is me, photo taken far pre-COVID, 2012. I've aged considerably since then. I'm a clinical psychologist with expertise in CF. I'm a human mom to two children, Siler and Raleigh, and a dog mom to two rescue mutts, Sandbox and Dogbert. So as we know, there have been massive medical advances in CF as of late. However, mental health addressing specific needs of CF patients remains a challenge. And as we know, anxiety and depression are much more common among CFers than in the general population. And this can be associated with decreased treatment adherence, reduced lung function, reduced health-related quality of life, and increased healthcare costs. And in particular, I'm thinking about no matter how amazing our treatments or medications are, if they're not actually getting into the patient's body because of non-adherence, then there's only so much we can do. So my hope is that our ACT with CF intervention can reduce anxiety and depression and also really improve medication adherence so that all of our CF community can take full advantage of these groundbreaking medical developments. So what is ACT? It's a new form of cognitive behavioral therapy, or CBT, developed by Steve Hayes in 2004. And the main goal of ACT is increasing psychological flexibility through acceptance of painful inner experiences, with the goal of moving towards your values, your core values, what you want to be about, what you want to stand for, despite anxiety, illness, or other obstacles. And why is ACT particularly beneficial right now? So let's think about Trikafta, right? Came out last September. What I hear from a lot of the CFers who I work with is that now that I have more time, both day to day, because you think about how Trikafta is reducing like symptom treatment burden by about 30%. So now that I have more day-to-day time and also much greater life expectancy and better quality of life, what do I want to stand for? What do I want to be about? And is more time always better? So I think about a patient of mine who I've worked with for several years, 38-year-old with CF, and he has been living in his parents' basement, smoking pot, watching video games, thinking that he was going to die at age 40. Thinking I've got a couple years to burn out doing what I'm doing. And now here's Trikafta. And all of a sudden he's got 40, maybe 50 years of life left, and thinking like, oh, wow, now I've got to stand for something. Now I've got to be about something. And then also, what about losses or survivor's guilt? Those beloved members of our community who weren't able to stick around long enough to benefit from Trikafta. And then I also hear a lot about living with regrets. If I'd known Trikafta would come, I would have saved for retirement, gone to college, gone to grad school. I used to work with a lady who said, if I'd known Trikafta would come, I wouldn't have married my shitty husband in my early 20s. She really wanted to have kids. She said, I would have waited. And then what about the remaining 10% of people with CF dealing with being left behind, at least for now? So really identifying and clarifying values, what you want to stand for, what you want to be about, has never been more important for CFers. And then of course, there's our good friend COVID-19. So thinking about facing a global pandemic with a life-threatening illness, and I know that the session earlier this morning focused just on this, including discriminatory health policies. So CF being on the list of chronic illness, chronic conditions that would deny access to a ventilator if there were a shortage in many states. stigma regarding coughing or appearing infected, stigma regarding strictness regarding social distancing. And this can really create a values conflict. So having the value of, being with friends and loved ones, and also having the value of like staying alive and not getting COVID. And, especially as the country is reopening and, people are taking more risks, the carelessness of our community really increases risk for CFers and can also leave CFers really feeling sort of othered and isolated in having to take the precautions that they often do. And again, there can be this values identification that's really needed, figuring out what do you want to be about, and then figuring out what are some committed action steps that one can take in the service of one's values. And then we got this sort of perfect storm of Trikafta and COVID. So many CFers will say, I've never felt better before, and I've never had a better prognosis than ever. And at the same time, having to be more vigilant, take more precautions than ever before because of the pandemic. And so how to remain vigilant in the face of personal physical health improvements. And here we can see another values conflict. So think about a lady who I work with who has CF. She can run a 5K now because of Trikafta for the first time in 15 years. And where she lives, they're going to hold an in-person 5K any week now. Should she go? It's strong value of hers to use her body to the best of its ability, live her best life. And at the same time, another strong value is stay alive, don't get COVID. So this kind of values conflict can really be seen a lot when you think about feeling great with Trikafta and having to be extra cautious because of COVID-19. And then last is telehealth really having a moment. So the COVID-19 pandemic, kind of to me at least, sole silver lining is that telehealth is much more widely accepted than it's ever been before. So insurances will reimburse for treatment via telehealth. We can practice temporarily, we can practice psychology across state lines using telehealth. And so our current active CF study participants can come from all across the country, which is just great. So, sorry, wrong way, this way. So let me tell you a little bit about the active CF pilot study. So as you know, CF symptoms often require a complex and time-consuming medication regimen. Here, CF is often associated with anxiety regarding shortness of breath, CF exacerbations, life expectancy, etc. And some people will choose to avoid following their treatment regimen to escape thoughts of having CF. And this suboptimal adherence can lead to worse symptoms, more shortness of breath, more anxiety, and this kind of vicious cycle. And so ACT helps people live the life they want without struggling with their inner experiences. So without having to avoid or turn away from painful anxiety or fears about the future, or depression, or survivor's guilt. And ACT is empirically supported as a treatment for anxiety, depression, pain, HIV, drug addiction. And it involves taking steps toward what you want to stand for now and jumping into your life with both feet rather than waiting until all of your ducks are in a row. And it also involves taking a stance of acceptance instead of denying or fighting or avoiding your problems. So I quite often hear, when my illness is under control, then I'll consider dating again. And I hear this from non-CFers, from people in my everyday life. When I've lost X pounds, I'll consider dating again. Whereas ACT would say, no, if your value is to have a close personal, close intimate relationship, take a step toward that right now. Don't wait for everything to be perfect. Move forward with your obstacles. So our pilot study was a 3-year feasibility study that we completed in 2019. We had 30 CF patients with elevated depression or anxiety on our PHQ-9 or GAD-7, and they got 6 sessions of manualized active CF, either telehealth or in person. They got to choose. The sessions were about 50 minutes each. So here, patients got to choose telehealth or in person. We did baseline assessment, and then after their 6 weeks of the treatment, actually we had a midweek, three weeks in assessment, and then afterwards we had a post-treatment assessment, and then 3 months later. And why telehealth, right? Reduces exposure risk, and especially now during our pandemic. It's great for, catching patients who might live far from the clinic. Our clinic is in Center City, Philadelphia, which some people choose to avoid. And you can get treatment in the comfort, of your home or while at work. And also you can still be getting the treatment during a CF exacerbation. So for example, if someone has to go to hospital during the course of their 6 weeks, we can just keep on with treatment while they're in the hospital. So we use WebEx for the pilot study. We're using Zoom for the main study. No real difference. I think Zoom has a few extra features that I like, but mostly this was just a sort of logistical decision. And 24 out of 30 of our pilot patients chose telehealth. And the telehealth format, both WebEx and Zoom, are HIPAA compliant. And here are 6 sessions, so 1 a week. The first is values. What do you want to be about and what gets in the way? And then the next is, what are you struggling with and how to use acceptance instead? The third session is all about committed action, taking steps toward your values. The fourth session is how to be present in this moment, so not get hijacked with like regrets from the past or worries about the future. The fifth session, thoughts are just thoughts, not truths. So your mind is not your friend. Your mind will generate all kinds of like doom and gloom radio station, and kind of how to take a step back from that, how to change your relationship to your thoughts. And then the last one is sort of a summary integration of all 6 sessions. So here are some examples from our pilot study patients. So some values that people came up with, and so these are CFers age 18 and up. We're having a relationship involving love and affection, making a lasting contribution, learning new skills, having an adventurous life, being self-sufficient or independent, having an enjoyable and leisurely life. All sound great. And then barriers being like, well, what's the point? Uncertainty about lifespan, wanting to avoid pain, lack of time or being too busy with work. It's not worth it for me to work toward my values, and then self-critical thoughts. And then for your defusion words, so cognitive fusion is like rigid attachment to your thoughts as truth. And defusion is kind of like cutting the fuse on before it can blow up the bomb. So kind of breaking this association between certain words and all of the kind of negative connotations that might be associated with them. So we asked people to come up with like, what's a word that haunts you? And then we did defusion exercises around that. And the defusion exercises are kind of fun. They might be like saying the word in silly voices or accents or like different animals or singing the word. And we also use several apps. So there's an app called Songify that can set words or phrases to various different like techno or bhangra or like country beats. So words that patients came up with were cough, suffocate, transplant, what's the point, I'll be dead soon, doctor, I'm never good enough, and expose, which is how the patient felt while coughing around others. And then patient feedback, people really love this treatment. So one patient said, working through ACT with its focus on actionable items has given me some great tools to work with the varied challenges of dealing with CF. ACT's a very refreshing form of therapy, different from other methods I've tried and failed. It's very practical, easy to fit into everyday life. And then results. So we found that ACT reduced anxiety and depression significantly on the GAD-7 and PHQ-9. Now there was a rebound of anxiety by the 3-month mark, remained reduced. And ACT also markedly reduced cognitive fusion. Remember, fusion is rigid attachment to your thoughts as truth. So for example, if you have the thought, I'm gonna run out of oxygen, like I can't breathe, I'm gonna run out of air, then if you're very fused with that thought, you will truly believe that, stop what you're doing, and not be able to function until you get your supplemental oxygen or similar. So, and there may be cases where that is the truth, and there may be a million other cases where that thought might be there and it might not be the truth. So cognitive fusion, defusion improved greatly. So, and that you see stayed improved at the 3-month mark, suggesting that ACT is 6 weeks of ACT is like fundamentally changing people's relationships to their thoughts. And then watch out, Vertex, ACT improved lung function. So this is just a trend, P equals 0.09, but still, come on, 6 weeks of a talk therapy leading to a change and improvement in lung function. Like, yes, please. ACT is portable, so there were no differences between telehealth and in-person treatment. Oh, I see someone's raised their hand. Well, I've got time for questions at the end, so don't forget your question. So both the telehealth treatment and in-person treatment were both equally effective. And the true beauty of this means, so just because of the logistics of how our clinic was set up at the time, we didn't have grant funding and we weren't able to bill for telehealth. So my students, master's level clinicians who I gave a one-day ACT training to, and then I would see weekly for supervision, they delivered all the telehealth sessions because we couldn't bill for them. And then the in-persons were all seen by me. So the fact that there's no difference between telehealth and in-person also means that we can train people in ACT and that it's portable. You know, this one-day training that I provided and then some ongoing supervision got my students up to the same level of, that I would be at. ACT with CF is really well received. 100%, every single one wanted to continue after the 6 weeks of treatment, and only one person dropped out due to pregnancy, and she actually came back after our study was written up to try to finish off her sessions post-delivery. So why did ACT improve lung function? Is it increased med adherence? Is it linking values to positive health behaviors? Reducing anxiety, so less avoidance of meds? People less depressed, they're more active, who knows? And this is kind of the million-dollar question for future study. And that's what we're looking at right now. So we've got this multi-site randomized control trial of ACT versus supportive psychotherapy to try to figure out, does ACT work better than just talking to someone? And so when we just finished year one of this, we can't look at the data until after all 3 years. So that's kind of the deal here. But so I don't have new data to report on this study, but stay tuned. So this is a 3-year randomized control trial of ACT versus supportive psychotherapy. We're trying to recruit 210 CF patients with elevated depression and or anxiety. And same thing, they get 6 sessions of manualized active CF or 6 sessions of supportive psychotherapy. Sessions last about 50 minutes each, and they're all via telehealth. We're generously funded by the Boomer Esiason Foundation, and we're piloting a new CF mental health and wellness measure. So our teams, I'm the PI, and then we have co-investigators at Duke, Patrick Smith, at Medical University of Georgia, Chris Drescher, and at UVA, Heather Brushwine. We've got my beloved research coordinator, Chelsea Nurse, who's been with me for the past 2 years. And we've also got a CF patient representative, Katie Lawless. And we've got our 10 master's level students working toward their doctoral degrees who I supervise, and they're our study clinicians. So Active CF is 6 sessions that we've heard about already, all delivered via webcam. And then the treatment as usual is 6 sessions of supportive psychotherapy, also all delivered via webcam. Same therapist doing both treatments. We're recruiting, so the beauty of the current sort of lift in telehealth related, the ability to practice across state lines with telehealth because of the pandemic means that, yes, we are recruiting from these sites, but we really also take all comers across the country. Unfortunately, I've also had some CFers from my hometown of Toronto, Canada reach out, and I can't practice in Canada even with the pandemic. But if you're living in America and you have CF and you want to be part of the study, we take all comers. Otherwise, these are our main sites: Jefferson, a few other Philly sites, Duke, Pitt, Augusta, and Virginia. So same thing, study procedures are the same, baseline assessment, then patients are randomized, like by a flip of a coin, to either ACT or supportive psychotherapy, post-treatment assessment, and 3-month follow-up. And we're piloting this new measure that was actually designed by me, by Katie Lawless, our CF representative, Darcy Cunningham, and Gunnar Esiason. So this is, I think, 3 mental health providers, 2 CF patients, and it's a really great measure. The goal of this measure is to capture symptoms of anxiety and depression often missed or confounded by CF-related symptoms or treatment side effects. Who's eligible? So anyone 18 and up, they have to have a diagnosis of CF, and then we're using a bunch of different measures so for inclusion criteria. So this is based on feedback that PHQ-9 and GAD-7 are filled out so many times that so many CFers can kind of just score 0 on that, despite actually having quite a bit of anxiety, especially during a pandemic. I mean, who's not anxious? So we're also using the BDI and the BAI, the Beck Anxiety Inventory. So to test in, to be eligible for the study, you've got to score over 4 on the usual suspects, PHQ-9 and GAD-7, or over 13 on the BDI or 9 on the BAI. Who's not eligible? So recent suicide attempt, psychotic disorders, other psychiatric disorders that might interfere with participation, or other medical conditions that could interfere with participation. And what we're looking at is primary endpoints are changes in anxiety and depression from baseline to after the 6 weeks to the 3-month follow-up. And then we're also looking at changes in lung function, other spirometry, cognitive fusion, acceptance, medication adherence, rehospitalizations and unscheduled office visits, starting antibiotic, scheduled CF clinic visits kept, change in BMI, and also patient-rated outcomes. So there's no cost to patients. We also don't offer any compensation other than a potentially life-enhancing treatment. 6 sessions, ideally 1 a week, all via telehealth. And if you have anyone that you want to refer to the study, or if you're a CF family member, community member, or you are a CFer, feel free to hit me up via email. Siri and the rest of the crew also know how to reach me. We're really open to anyone who's interested in participating.